It is 8 o'clock, and so we are going to go ahead and get started. Um, Welcome. We're so glad that you're here on this fall October morning for our ABIN monthly webinar. We have an exciting team today, and they are from the Bowman Foundation. And so we have been talking to the Bowman Foundation and learning from the Bowman Foundation for a long time. And their publications and their research has really shaped COCM across this country. And so I'm so grateful today that they're going to talk to you about COCM, the efforts that they have been making to advance COCM across the country, some of the work that they've been doing with research policy and really driving COCM forward. And so I'm so honored today to have with us Mr. Matthias Bowman, and he is the president of the Bowman Foundation. Mr. Bowman leads initiatives focused on improving access to behavioral health care and advancing evidence-based mental health research and policy. He previously served on the board of directors of the Brain and Behavior Research Foundation, the American Cancer Society Foundation, the Sylvan Herman Foundation, and One Mind. Before his work in philanthropy, Mr. Bowman held senior leadership roles in finance, including vice chairman of investment banking at Merrill Lynch and chief executive officer at Merrill Lynch Ventures and other private equity funds. Mr. Bowman graduated summa cum laude from Williams College with a degree in economics and earned his MBA from Harvard Business School, where he was a Baker Scholar. He also pursued postgraduate studies in molecular biology, neuroscience, and biostatistics. And we have his colleague, Mr. Michael Uhas, joining. And Mr. Uhas serves as an advisor to the Bowman Foundation and the Mental Health Treatment and Research Institute, bringing decades of experience in behavioral health management and community-based innovation. He's the founder of Integra Service Connect, a company dedicated to engaging high-need individuals within their own communities to improve health outcomes and care coordination. Previously, Mr. Uhas served as Chief Executive Officer of Health Integrated, an integrated managed care company, and held executive roles with Magellan Health Services. Mr. Uhas earned his master's degree in clinical community psychology from Temple University and completed additional graduate training in psychiatric epidemiology at the Johns Hopkins Bloomberg School of Public Health. And we have Ms. Kristen Pendergrass. Ms. Pendergrass serves as Vice President of State Policy at Shatterproof, where she leads efforts to advance evidence-based addiction policy nationwide. She previously held her leadership roles at the Pew Charitable Trust, guiding state strategy for substance use prevention and treatment initiatives in the Pew MacArthur Results First Initiative. Earlier in her career, she served in policy and legislative roles in both Oregon and Massachusetts state legislatures. Ms. Pendergrass holds a master's degree in social welfare policy from Boston University and a bachelor's degree from Vanderbilt University. So you can see we have a very experienced, very impressive team with us this morning, and they're going to share a little bit with you about the work they are doing. I want to remind everyone that by staying on today's webinar, you're giving us your permission to be recorded, and this recording will be posted to the ABIN website. Without further ado, I'm going to turn it over to our esteemed COCM team today to talk to you about the work they're doing.
Thanks very
share
much.
My screen here.
Thank you, Michael.
Okay. All right, Matt, why don't you kick us off?
All right, thank you, and thanks to ABIN for inviting us today. We're here with our partner, Kristen, from Shatterproof. Our foundation, which we nicknamed BFF, has supported Shatterproof and collaborated with Shatterproof for many years on a number of projects, but most especially regarding integrated care. And I'm just going to take a moment. Kim already mentioned that our our mission is to improve the lives of people with mental health or substance use conditions. I'll mention just people ask me, why that? And I'll just say one of our children has severe mental health and substance use conditions. And we've got lived experience both with these illnesses and the challenges of getting adequate care. And we decided more than a dozen years ago to focus our time and money and efforts on helping everyone get better access to effective care, both from mental health and substance use specialists, and most particularly in primary care. And our family story is like a lot of people with 2020 hindsight. We now know that our son's condition was detectable and could have been treated in fourth grade, fifth grade, but we didn't. We were ignorant, and we didn't get any care until after he had failed out of college. So that's a 10-year, loss. And of course, if you can, treat an illness earlier, you can bend the curve. So we're working to bend the curve for, all Americans. So with that, I'm going to turn it over to Michael. And Michael, are you sharing your screen, or can you?
Yes, can everyone see the slide on the screen?
Yes, I can see it.
Oh, good, okay. But this is always a crapshoot for me, so I can't, I think I can see it. Okay, so I would just ask Kristen, if you'd like to say a few additional words about Shatterproof before we get into the meat of a lot of these slides.
Sure. Hi, everyone. Thank you so much for having me. Again, I'm Kristen Pendergrass, Vice President of State Policy at Shatterproof. I'll say a little bit more about Shatterproof later and kind of how we got founded, but we are a national nonprofit dedicated to ending the addiction crisis. So we work in at making sure people have access to quality addiction treatment. We work on ending addiction stigma through national and state-based initiatives. We also have a number of initiatives around educating people about substance use disorder. We are currently in our walk season. So around the country, we have a number of walks to bring people together and advocate for substance use disorder policies. So again, I'll say more a little later in the presentation, but thank you all again for having us.
Thanks, Kristen. And I should mention that we will share the slides that you're seeing after the presentation today. We want to go back and make sure that we may not need to add anything or all of the links work and things like that. But just be aware this will be shared, if not today. And so again, echo Matt and Kristen's comments. Is there a question?
Yes, I was just going to ask. It's a little hard to hear you. I don't know if you can increase your volume, that would be wonderful.
Sometimes this helps. Is that any better?
I think maybe a little better.
Okay. Can people hear me? Just raise a hand if you can hear me well enough that I don't need to do anything. All right, the hand went down there. Okay. Let me just check my settings. Sorry.
No problem. All these technological pieces. We just want to make sure we capture you, so we have the recording.
Just want to check my audio. Fortunately, that looks okay. So what I'm going to do is I'm going to take my headset off and just go to the speaker that's on my monitor. If you can hear me say that.
Yes.
Okay. Can you hear me now?
Yes,
Mhm.
Okay, now I need to turn my volume up, but,
that was much better. Thank you.
oh, sure, sorry about that. So back to the presentation, let's find it. Okay. Okay, so as Matt was saying and Kristen added to, what we're here to do is really, we were asked to provide information on the activities that our organization, initially the Bowman Family Foundation, is doing relative to increasing access to care, and specifically our efforts around collaborative care, or generally speaking, evidence-based care. So as Matt and I were thinking about it, we thought it would be good to add Kristen to the presentation, which is why her bio sketch wasn't included in the original announcement. So that will come following the meeting too. But the on the bottom part of this slide, we collaborate, as Matt said, on a number of issues that are in common to what we both believe in. And in particular, the last two bullets on this slide, increasing access and the evidence-based focus, really trying to get past the sort of the typical well-intentioned advocacy, beyond that to get to some actual concrete steps that are being taken that produce outcomes that we can see. Is there a question?
How are you? Great, how are you?
There we
Is
go.
I can't tell if that's background noise or a question. I'm sorry.
I think that's background noise. We're going to go
Okay.
ahead and make sure.
All right,
There
thank
you
you. I didn't want to have to answer it if it was a question. Okay, so one of the things that we do want to talk more about today, because our big focus in terms of evidence-based care is measurement-based care, or measurement-informed care, it's also called, as well as the psychiatric collaborative care model, COCM, which most of the people I expect have at least heard of that on this call, and many are probably deeply knowledgeable about it. So in terms of what we look at in accessing some of our access efforts, what we're focused on is quantifying information so that we can help decision makers make informed decisions based on true data and not subjective or impressions. So we focused a lot along the way on actually documenting how difficult it is to get access to mental health and substance use disorder care. And these efforts include these documents and studies that are shown here will be links that you can access on the Bowman Family Foundation website. But in the NORC survey, we worked with the organization NORC to do a survey of patients, providers, caregivers, to get a determination of how difficult it really is to get care. And when you look at that report, you'll kind of get a confirmation of what everybody already knows if you try to seek mental health care. It's not easy. The NORC survey report documents and quantifies a substantial amount of the difficulties that people have in doing that. The RTI study, the Research Triangle Institute, we worked with them to really look at some of the factors that might be influencing the availability of providers. We looked at things like differences in reimbursement for mental health providers versus med-surg providers. We've looked at out-of-network use for med-surg care versus mental health care. Not surprisingly, there are differences that you might expect in both of those metrics. The updated and expanded Milliman disparity study continues to build on work that's been done earlier to further quantify the gaps that we have, the difficulties people run into getting care. And also because we want to we want to make sure that the people know that what we're doing right now in terms of treating these conditions, mental health, substance use, is subpar by quite a long measure. So as we're building our case and database, we're assembling information on some of the limitations in treatment as usual. For example, most people get care for mental health and substance use disorders from the primary care provider. Yet less than 15% of the care that's delivered has been documented as being effective care. So we know there's a gap there in terms of the way these conditions are typically treated. And we're looking, again, assembling all of the data points to figure out where does this lead us. So it's hard to get care. There's a differential in terms of reimbursement, out of network use, that makes it harder to access these mental health specialists. Providers in primary care see these patients, but they're not able to do a lot. The Voice of the Purchaser survey was similar. It was done on 220 employers by the National Alliance of Healthcare Purchaser Coalition and the HR Policy Association. Once again, from the viewpoint of employers who purchase healthcare, are saying, you know, mental health substance use care is a big issue for us. We are focused on, you know, making it better, but then how they address it differs. But the main message there is it's a big issue for every employer, mental health substance use care. And then lastly, another thing that we focus on in terms of improving access is developing tools to actually assess how adequate a network is relative to its to the providers of mental health substance use specialty care. And so there have been tools that we'll just briefly touch on today. The model data request form was our attempt to systematize and quantify some of the factors that look very clearly like they lead to the unavailability or lack of availability of mental health specialty care. So the model health data request form is a quantitative tool that we put out, and it's used by organizations, it's used by state governments, really to just try to quantify in a more systematic way whether it's a network is adequate in terms of meeting mental health needs. Okay, this is the North report that I referenced. You'll find that on the website. This is the RTI report that, again, these are continuing to build on what we already know from a bunch of literature, that it's much more difficult to get care for behavioral health than for medical surgical care. And this, again, is a deeper dive. So these are examples of the efforts that we've gone into, and the Bowman Family Foundation has funded to develop quantitative data to make sound arguments. I mentioned the MDRF. These are the 5 features of the MDRF to try to systematize the adequacy of a network and what may be getting in the way. We look at things like out-of-network use, differential, in-network reimbursement, actual participation, denial rates, utilization review. And it's a tool that's been endorsed by a number of organizations and used by NCQA, as I mentioned. I'm going to stop and ask if there are any comments or questions on this last group of slides. Okay. Then I'm going to ask Kristen, as she mentioned earlier, to talk just a little bit more about what the what Shatterproof is doing to support the efforts we're talking about.
Sure. Thanks, Michael. I told everyone that I would share a little bit more about Shatterproof and how we were founded. Our founder is Gary Mendel, who lost his son as a result of his addiction to opioids about 12 or 13 years ago. So we are a national nonprofit. We've been around for about 12 years. And Gary created the organization to provide the kind of services and supports that would have been helpful for his family. And so, as I mentioned, we focus on increasing access to quality addiction treatment, ending addiction stigma, and educating and empowering our communities. And then kind of an umbrella of all of that is the work that me and my team do around advocacy. So there are 2 main things that we focus on with our advocacy. The first is preventing substance use disorder, and the second is ensuring access to quality care for everyone. So we started working on the collaborative care model probably 4-ish, maybe 5 years ago. And it fits into both of our priorities for advocacy. The first is in prevention. It's not primary prevention the way most people think of it, but secondary prevention, where you're looking at early intervention, early screening. So the collaborative care model, urges all primary care physicians to screen everyone for behavioral health conditions. And so if someone screens for a substance use disorder at their primary care doctor, they're able to receive treatment much sooner than if they wait and end up having to go to specialty treatment. And then secondly, ensuring access to quality care for everyone. Michael mentioned the number of primary care providers who are treating substance use disorder, but not necessarily giving the highest quality evidence-based care. And the collaborative care model, which is visualized here, gives a primary care physician support through that psychiatric support, a behavioral health specialist who's able to support the primary care provider to make sure that they are providing the most evidence-based and effective care for people with substance use disorder. A lot of the outcomes data focuses on depression and anxiety, which of course we know that mental health and substance use disorder cannot be divorced from one another, but there's also a lot of evidence showing the effectiveness for substance use disorder in particular. Two other things that led us to work so much on expanding the collaborative care model are the return on investment. This has been very appealing to states who are obviously worried about healthcare costs. And I'll give a couple of state examples in a second, but that positive return on investment showing that, identifying and treating a substance use disorder early can actually save money in the long run. And then secondarily, the collaborative care model has been shown to reduce disparities. We know that people of color are often not treated with as much high quality care. And so the collaborative care model actually reduces disparities in care, which is also very important for us. So as I mentioned, we work around the country. We've been working specifically with state governments to turn on the collaborative care model codes for Medicaid populations. When we started this work, I think there were 14 states that reimbursed for the collaborative care model codes, and you can see the progress that's been made. And we are continuously updating this slide. Some of the states that are green do not fully reimburse for all healthcare conditions. New York, for example, reimburses for mental health, collaborative care treatment, but not necessarily substance use disorder. So it's not quite as black and white as this slide shows, but some recent gains include Kansas, where they turned on the codes in January. And we talked to a provider the other day who is providing collaborative care in Kansas and showing really impressive outcomes in just a short period of time. Texas is a state where I mentioned the return on investment. They passed the collaborative care codes through the legislature, and every bill that goes through the legislature gets a fiscal note, is what it's called, and that basically shows how much it's going to cost over the long run. And in Texas, they gave it a $0 fiscal note because they noted that the long-term savings for emergency care would offset any short-term costs that might happen with increased reimbursement rates. A couple other approaches I want to highlight. Maryland started the collaborative care model with just a pilot where they took a couple of facilities and tried it out. They showed, and Matt and Michael have worked directly in Maryland, so they can talk much more about what's happened there. But hey, they had such good outcomes that they ended up passing legislation to fully reimburse the collaborative care codes for Medicaid just a year or two ago. And then one other state I want to mention is Georgia, where we spoke with the Medicaid office and they decided to turn on the codes. And then after they turn the codes on, they're starting to think about, okay, what other support do we need to provide to facilities and to individual providers to make sure that they're able to fully reap the benefits of the collaborative care model. So I'll leave it at that unless Michael and Matt, you want me to talk more about anything in particular or unless people have questions.
Good here.
It's fine. Thanks, Kristen.
Yeah.
Thanks, Kristen. Okay, so this slide sort of shows the flow of why we are focusing on collaborative care. And just to kind of set the stage for this, we're aware that Arkansas is not yet paying for collaborative care under Medicaid. We know which states do and don't. We would love it if the state started paying tomorrow, but we're not here to do arm twisting. We were asked to really describe what we're involved in and why we're involved in it, why we are so committed. So just to kind of set the stage for this, we are focused on evidence-based care, which to us boils down to two major initiatives. One is measurement-based care, actually, doing the equivalent of taking a blood pressure check on every patient that may have a mental health and substance use need. We need to do systematic screening. We need to do ongoing measurement of symptoms to determine if the patient's actually getting better and by how much. And this is woefully inadequate right now. And then even among behavioral health specialists, the percentage of providers who actually have implemented measurement-based care, a systematic way of monitoring these things, is very low. The uptake has been unfortunately low. But the second area we're focused on is behavioral integration, and really this flows from a couple of things. There aren't enough specialists. We already know that, and more importantly, perhaps, there are not enough specialists who are enrolled in insurer network, which is why you see a lot of out-of-network use among patients seeking mental health substance use care. So there aren't enough providers to start with. And of the ones that we have, half of them, give or take, participate in insurance network. So that's a major issue, given that insurance of one sort or another is how most Americans are able to get healthcare services. The second bullet here under integration, we know that most mental health substance use conditions are already being treated in primary care, as we said. They're just not being treated especially well because we've not equipped those providers to do a good job, or as good a job as they could and should be doing. This has led us from behavioral integration. There are a couple of models out there that you all, I'm sure, are familiar with. The PCBH model and the collaborative care model are the two most common that we see out there. At the Bowman Family Foundation, we've explored all of the sort of models that are available and have really reached the conclusion that from the standpoint of a substantial evidence base for clinical outcomes, financial outcomes, provider satisfaction, patient satisfaction, almost any angle you look at this from, collaborative care has established a very sound evidence base. And it's not there yet for some of the other models we've seen. Not saying they're not effective, they're not working, but we know that the collaborative care model does, and we know there's a ton of evidence to support it, including nearly 100 collaborative studies on collaborative care that have been randomized, controlled trials. So we know the evidence base is there. And specifically, what we are focusing on is how does increasing access through collaborative care to mental health treatment, how does it impact total healthcare costs? And intuitively, we kind of know that when people have a mental health problem and a co-occurring physical health problem, one or both makes the other worse. And we know from a lot of literature that that is in fact the case. If you look at studies that have been done by Milliman and other organizations, we know that having a co-occurring mental health problem increases your costs, total care costs. Secondly, we've begun to see a lot of research and a lot of interest in suicide, the impact of suicide, given that most people who've committed suicide have seen their primary care doctor in the last year, and half of them in the last month. So we know that the primary care setting is an opportune setting because people are already coming in with mental health problems. We know that people who are going to commit suicide are seeing their primary care providers. And so this has caused us to say, okay, well, how strong is the database and what can we do to improve this? And then this third bullet, one of the things that we keep running into is if you think about the implementation of collaborative care in a primary care practice, if that primary care practice has a patient panel of 90% Medicaid patients, the provider is not going to be reimbursed if Medicaid doesn't pay for collaborative care. And we're asking them to change their workflows and entire ways of doing things for a panel, 90% of which they're not going to get reimbursed for collaborative care. So what we've discovered is when Medicaid does pay, it means essentially all payers pay, because Medicare pays for collaborative care. Most, if not all, commercial payers pay for it. So Medicaid is the big missing one. So that's why our attention has been drawn to Medicaid. We see this as an important thing to attend to. The next big bullet is we work with organizations that are trying to help providers and health systems operationalize measurement-based care, collaborative care. We think there should be more of them. This should be made easy. Kind of behavior change 101, make it easy. If this is difficult, fewer people will do it, full stop. Next to last bullets, we try to create resources for interested practices and systems that want to implement by providing tools and resources. So this directory of collaborative care service organizations, which is being updated right now and will include ABIN, is a group of 32 organizations that have built themselves up specifically to provide behavioral health integration services, and collaborative care is a primary focus. And then the last bullet here in terms of our strategies to improve evidence-based care is to work with decision makers, influencers, make policy recommendations based on all of the data we're gathering as to how to put this into action. So that's that's how we got down to collaborative care as a key area of focus. Everything we see tells us this is something that we ought to be doing. We did a paper a couple of months back in terms of looking at studies that were out there. Some of you who are familiar with collaborative care know that the original impact study, the first study you see cited here, this issue brief looked at 3 studies and found that with the original impact study, there was a return of 6 times the cost of COCM. So you put $1 into COCM, you get $6 back. With Kaiser, they did their own study as well, saw a 13% decrease or 13% savings, PMPM, after a year of collaborative care being put into place. And the University of Pennsylvania did a study with Independence Blue Cross and showed this was a non-statistically significant figure, but $30 PMPM less for the collaborative care group. So this is just our way of saying, let's sort of look at what we have more recently, going back to impact and more recently, to support this contention, and we're finding it. It does save money. So then we looked at suicide, and we did a similar issue brief recently this year that showed large reductions in suicide risk attempts and deaths. And we looked similarly at 3 different studies that had been done: Concert Health, University of Pennsylvania again, and Kaiser Permanente. These were studies that focused on suicide. In the previous slide, that studies from both the same organizations were focused on total cost of care and cost savings. So not surprisingly, when we looked at the key studies that are out there, this is the Concert study, this is the University of Pennsylvania study. Kaiser we didn't put on here, but when we look at these things, this is what you look at. This is what you come up with. Like in Concert, more than half achieved a reduced risk for suicide behaviors. University of Pennsylvania, more than 50%. Kaiser, 25% reduction in suicide attempts and deaths combined. So we're looking at all of the research out there. We're helping in some cases to fund these research projects and then issue briefs as we're doing here. But we were involved with funding these 2 studies, at least partially funding them, and then put this together based on that plus Kaiser. So this was important because suicide is really something that's gained everybody's attention, rightfully so. And this was the first time that the American Foundation for Suicide Prevention and the JED Foundation have stood up and urged implementation of collaborative care. You can see their comments in the press release link when you get this, but the studies confirm the value of collaborative care for saving lives and helping people at risk of suicide. Time to embrace the model. these are important. These are important comments that major organizations have come to the conclusion to support collaborative care. The strategies, again, continuing here, to generate data. This is the Medicaid point I was talking about. In the CONCERT 10 state studies, which I'll just briefly touch. And then we are involved right now in the national study of commercial claims, looking state by state to basically enumerate the volume of collaborative care services in a number of different ways. Who's using it, what providers are delivering it. It'll be very comprehensive, but it's not ready just yet. So that's in progress. And then we did we're doing right now, the draft, look at how states are reimbursing for Medicaid, the variability. This is the CONCERT study. So what CONCERT did was what we're calling the 10 state study. Okay, so what they did is they looked at 10 states. CONCERT Health is a large collaborative care service organization. So this is a company that will go into a health system for a group of provider practices and basically offer a turnkey collaborative care program. They'll provide the behavioral care managers, psychiatric consultants, the technology, the reporting, help with the billing. They do it all. And so they looked at their book of business in 10 different states and looked at basically the uptick in collaborative care being provided. Again, this is their book of business, but they have a huge book of business in terms of collaborative care patients. And they were finding, not surprisingly, that where Medicaid is paying, you'll see a lot more being done in collaborative care by commercials and Medicare. It's like the tide that raises all of the boats. Another study that we looked at with CONCERT, this was in Massachusetts General Brigham. In 2023, they started providing collaborative care services as a turnkey organization to Mass General Brigham. And they have now, 2 years later, they have 1,400 patients right now, this month, that are receiving collaborative care, and 8,000 patients overall in 2 years, and a total of 162 providers, primary care. So referred patients just this past month, September, 162 providers, 1,400 receiving. So this is something that when it takes hold can move fairly quickly, which is important because you do want to see kind of the impact and the return on the investment. This is a slide I mentioned briefly that is still being put together, which is why you see draft on it. But this was an attempt to use publicly available information, go to the websites, the Medicaid websites in all of the states, and trying to determine how their reimbursement level for collaborative care. And what you see here is our attempt to group these. And we looked at really the two most common codes, the 99492 and 3. These are the most commonly submitted collaborative care codes. You'll see down here, the green font says that these states pay at least 100% of Medicare for at least the 99293 and 2 and 3. So those all pay at least 100% of Medicare. The blue pay for at least 100% of Medicare for at least one COCM code. But we're playing with this information because we're saying, okay, this let's assume we have all the wrinkles ironed out, but 90% of or more of Medicare for these two codes, this is the grouping of states that goes in what we're calling group 1. States that pay 70 to 98, 70 to 89%, group 2, below 70, group 3. And these are states that do not yet reimburse for collaborative care. There are 13 of them remaining. And then we have a couple down here that are special situations. What we find when you look at this stuff, it's not as easy to say yes, no, they pay for collaborative care. They don't. There are so many different ways of doing it because of the state's ability to do it, how they determine is appropriate. This study was done by CONCERT. They did a follow-up and they looked at pre and post provider provision of collaborative care. They looked at patients receiving and providers providing collaborative care before and after collaborative care was being reimbursed for Medicaid in Connecticut. And I didn't include the slide here. It's one of those things we can maybe include as an appendix or something later. But you can also go to the Bowman Family Foundation website and look at these. It's remarkable. It's like astounding how the uptick went immediately up after Medicaid payment was passed. This is the Directory of Service Organizations, those companies that help practices and systems implement. And just a final comment about what we're doing kind of out and about nationally. We're also doing some state initiatives. We're funding the Massachusetts Association for Mental Health, the Mental Health Association of Maryland, and a subsidiary, Brain Futures, to engage in activities that will increase the uptake of collaborative care in their respective states. And these projects are fairly comprehensive, and the Bowman Family Foundation and its subsidiary McCarry Mental Health Treatment Research Institute. This is the kind of opportunity we look to. We want to find local champions that can put some of these important things in place. Last comment, we make a number of recommendations, policy recommendations I mentioned. And this is just sort of to illustrate a couple of things. One, this is an example of a recommendation we make. We've made this in a couple of different publications to allow in-network collaborative care services, if they're delivered in accordance with CMS requirements, to be counted as in-network mental health substance use care specialty services. So that's an important one because a lot of payers, a lot of network administrators generally are grappling with one, the insurance division in their state will have very commonly minimum requirements for ensuring adequacy of access to mental health care. Mental health parity legislation has incredibly clear and strong requirements. And so we're saying here, if you are a payer, for example, it would seem like you'd want to get credit for your behavioral health network access by having that care provided, still behavioral health care just provided by primary care providers, count towards your network adequacy evaluation. So that's an example of a recommendation that we think ought to be, everybody ought to support that. Through the work we've done, we do a lot of advocacy behind the scenes and very openly, but a couple of things that have happened that we feel particularly comfortable about because we know that we're very involved in advocating for. CARF has introduced in its Behavioral Health Standards Manual a requirement for organizations to incorporate MBC. This was, I think, in a 2025 manual. So this is very gratifying when we see the effort start to pay off. We're starting to get noticed. And now HEDIS counts follow-up after hospitalization for mental illness as a metric that you can use with the collaborative care for. And then lastly, more than 50 organizations have supported the recommendations we proposed. I haven't counted them lately. It's probably a lot more than that, but in any event. So that is the end of our formal presentation. I'm going to stop and let Kim or anyone else who wants to take the lead here.
Perfect. Thank you. Sorry, it took me a second to come off mute and darkness. But this is an opportunity. First of all, I want to thank all three of you for sharing this wonderful information and talking about your work and really the research that is driving COCM. And so for me, one of the takeaways were you all have looked at behavioral health integration models and looked at what was making the best possible outcome, and it happened. That's why you chose COCM. It's because you're seeing all of these outcomes. And so I want to open this up to our audience to ask questions. It's not often that we have people who are national experts in showing us these are the national studies that are happening that are driving our care. And so I'm going to ask. I know we've got some folks on that are either doing COCM or thinking about COCM. And so this is our time to ask some questions. I'm
There
gonna,
may be some in the chat. I haven't been following the chat, but please
yeah,
ask questions.
absolutely. I and I don't mind kicking us off. I'm not shy. One of the things, so for me, I have to say it was extremely impressive to see the slide where you showed these the different groupings of how Medicaid is paying by state. Some states are paying above 100%, some states are paying 70%. Can you talk a little bit about what the uptick looks like on states that are not paying over 100%? Has it been more challenging to get practices to adopt that? What does that look like? And yeah, we could start there.
Yeah, I'll take that, Kim. The answer, yeah, my background is economics and finance, so I may have a different perspective than many people about healthcare, but it's clear that when payers, not just Medicaid, but when Medicaid and commercial have higher reimbursement for collaborative care, you get more collaborative care. Now, it's not a straight line regression because fortunately there are, I'll call them healthcare champions of collaborative care who, even in states with low Medicaid reimbursement and low commercial reimbursement, they just decide we're going to do it. It's the right thing to do. And so in Pennsylvania, where commercial reimbursement is relatively low to other commercial reimbursement states, and Medicaid reimbursement is low, the University of Pennsylvania, their Penn Medicine system, decided 6 or 7 years ago, we're going to do collaborative care. And so in Pennsylvania, you have quite high use of collaborative care because of one strong provider that just said we're doing it. And interestingly, when you ask them why are we doing it, they said, well, it's the best care, but it will save money. Okay, so their system in primary care has a lot of contracts where they're at risk. They have a bundled payment for the patient, and they're at risk if the patient has above average costs. And so they believe that if we implement collaborative care, we will have a better economic outcome on our bundled payment patients. Kaiser is a collaborative care champion. They're rolling it out in all 8 of their regions. And early on in 2015, they did 2 studies. They had a pilot program in one state, basically, and they did a study of clinical outcomes, which turned out to do very well, and they did a study of total healthcare costs. And it's the study that showed a 13% reduction in the collaborative care group versus the non-collaborative care group, a similar group. So they said to themselves, you know, it's better outcomes and it saves us money. They don't do billing codes because they're the insurance company and the provider, bundled. So they just decided to do it. In Massachusetts, one major hospital started doing collaborative care 7 or 8 years ago before there was payment codes for Medicaid. They just said, and they decided, we're going to do it. We're not billing anybody. They didn't bill commercial, they didn't bill Medicare. They just said it's so good, we have to do it. Now they're billing because, now it's gotten much bigger and now they're billing. So a champion can bend the curve and have use be higher than you would think. But on average, we talk to many of these, we call them CSO, Collaborative Care Service Organizations, that are in the directory, and they basically tell us, in a state with low Medicaid reimbursement, or none, but even just low Medicaid reimbursement, we had very few clients who adopt collaborative care. Not nobody, but if they have more than 10 or 15% of their panel is on Medicaid, in a low Medicaid state, most providers will not adopt collaborative care. Not that they don't want to, if they can't afford to, not get paid or not get paid adequately for, 25% of their patients. They just can't afford it. So yes, there is a distinct relationship between reimbursement, not just Medicaid, commercial also, and uptake, but it's not a straight line because of champions.
Okay. No, that's extremely helpful. Thank you, Mr. Bowman. Any other questions around that piece? Okay, we did have a question that came in. The question in the chat is there anything being done to educate and encourage adoption for states that are not receiving reimbursement?
Well, we'll let Kristen take that one.
Thanks, Matt. Yeah, there's a lot being done. Webinars like this are one way that we're trying to educate people about the benefits of collaborative care. There's a lot of cross-state learning. So, for example, someone in Kansas, the person that I mentioned earlier, was curious about how other providers are experiencing this, and so we introduce them to someone in Georgia who's been implementing this for a long time. We meet regularly with Medicaid offices, legislators, trying to encourage the adoption of the codes. So yeah, there's a lot of organizations and individuals working on this to try and get the word out. And not only to get the codes turned on for reimbursement, we focus a lot on Medicaid, but there are people who are also working for the private payers, trying to make sure that they're aware of the benefits of collaborative care and getting them to not only turn the codes on, but as Matt and Michael talked about, increasing reimbursement to increase uptake in primary care offices.
Yes, and I should mention there are payer champions as well. So in two that come to mind are Blue Cross of Michigan and Blue Cross of Massachusetts. In Blue Cross of Michigan, for many years, they have actually helped fund practices that want to adopt collaborative care, and they have some startup costs, and they can get grants to cover those startup costs, and they Blue Cross of Michigan pays for training of practices, and they have a commercial now. They have I don't know all the details, of course, but they have a a method of giving, a relatively high reimbursement on the codes, as well as bonus payments for certain levels of adoption. And they have, by and large, waived patient out-of-pocket expenses for collaborative care, which is another very important step you can take. 'Cause even if a practice offers collaborative care, if the patient can't afford the out-of-pockets, they won't accept the care, and that's really tragic. And Blue Cross of Massachusetts has done a similar thing with, intentionally bringing up their reimbursement rates, and they've eliminated most copays in Massachusetts. So, and even in states where Medicaid fee for service does not pay, some MCOs have paid, and we'll call them champions. So in Tennessee, which for years did not have, didn't have Medicaid reimbursement, that's the shorthand. But that really means fee for service didn't pay. But the MCOs, a number of the MCOs, have paid in Tennessee anyway. So, I can't speak for them, and I don't know them, but part of it was probably they realized they would save money if they had patients with collaborative care. So, peers can be champions as well.
That's awesome to hear that there are some, some pair champions across the country that are, the example showing us if we make these adjustments, if we don't have copay, we could see increased people participating, and we can see these increased outcomes. And to hear in Massachusetts that the hospital believed in this and saw such benefits that they started this before reimbursement was even happening, that speaks volumes. Wow. So to answer your question, yes, it sounds like there is a lot of education happening across the country. And part of what we want to do, thank you, Kristen, for pointing out, is today we're bringing this webinar to Arkansas so we could start providing some education on what's happening across the country, and maybe some components that we could bring here as well. So.
I would mention one other thing. We talked just briefly about some of the state initiatives and working with Massachusetts and Maryland. Another example is we worked earlier this year through the Massachusetts Mental Health Association, is very involved with the Massachusetts Health Policy Forum. We put on pretty much a whole day meeting, in-person meeting, a conference dedicated to advancing collaborative care throughout the Commonwealth. If you go on the Massachusetts Health Policy Forum website, they actually have a link to documents. There was a position paper put together beforehand. You can get information from the conference itself. But it's another example of how we will try to work with local partners to help influence larger groups of people. And they had pretty substantial turnout there. So it's just one single example, but those add up.
Yeah, no, that's fantastic. Amazing. We're down to 1 minute. Does anyone have a last minute burning question? Let's see. Anything else in the chat? I guess with 1 minute, want to ask, have one question about employers. Have you seen any independent employers engage in this, or employers who are self-insuring their employee population? And what does that look like?
Well, I'll just say quickly, and if anyone has questions about this, they can write us. we work a lot with the National Alliance of Healthcare Purchaser Coalitions, which is a long name. That's a group of 12 or 13,000 employers. Okay, these are commercial employers predominantly, but also state as employers, big cities as employers, universities as employers. These are the members of the National Alliance, and they've come out strongly recommending collaborative care. And in most of our issue briefs, when we ask people to sign up as supporters, we normally get more than a dozen employer coalitions supporting our recommendations about collaborative care. So they want it, but they don't have contracts with primary care providers by and large. They have to rely on their TPAs.
That's extremely helpful. I know we're at time, but I have to ask this last question. If you all could just give some brief suggestions, guidance on how Arkansas could and or should move the needle with COCM, what would you tell us? What should our next steps be?
Well, I'll take a stab at that. I think number one is educate more providers. Number two is I know this is like, if I had a magic wand, you would do this. You would have the state and ideally the MCOs. I know Arkansas has, I don't understand the Arkansas Medicaid adequately. So I'm over my head here, but again, MCOs can pay the codes even if the state is not yet at the fee-for-service level. So that, I would educate the MCOs and of course the state. And I know you've tried that and it's not a new topic. But with the state world, I would emphasize the cost savings from collaborative care. And it's not, way out there 10 years from now, it's, soon, cost savings. We've got 3 studies in the issue brief that we did. There are more coming out now. And, with any state, just even getting to the controller of the state or the treasurer of the state to show that this can save money. And we funded one other study that Michael didn't put up, but it's on our website, called the high cost study. And what that study shows, it was a collaborative care study, it showed that if a person has any mental health condition, mental health or substance use condition, their medical costs are 3 to 6 times higher than a person without a behavioral health condition. Not 30 to 60%, 300 to 600% higher. You don't have to be, a finance analyst to see if you can, and these were true with people with mild to moderate depression, any mental health or substance condition, 3 to 6 times. This was all based on claims data. That this was not a projection or a algorithm or something. This was insurance claims data. 3 to 6 times higher. So, you know, if the argument that it's better clinical care is not enough, bring in the economics.
Kim, I might just add one thing real quick. My
Yeah.
background is in state advocacy. You all have state legislators. We've seen bills in Arkansas introduced in the past couple of years to cover collaborative care for Medicaid. So everyone's got a state legislator. You should reach out to them and see if they're on board. Maybe we can get it over the finish line sometime soon.
Love it. Michael, any last advice or thoughts for us in
Say,
Arkansas?
coming at it from a slightly different angle, you just look at where the obstacles are for it moving forward, because different stakeholders have different needs and they have different issues. So the same answer isn't equal for everyone. It may be more financial, it may be more clinical, it may be more efficient. There are lots of reasons, but I think when you think about it, it's not the same answer for everyone, because there are certain issues that resonate more, and you will have some of that local lay of the land. And we're happy to talk with you after this call.
Okay, wonderful, wonderful. Well, thank you all for taking the time out of your schedule. I know you all are located across the country. It was wonderful to have you virtually in Arkansas. Hopefully we'll see you here. We would give you a warm Arkansas welcome. And we truly appreciate the work that you are doing. You're changing behavioral health care across this country. And we can't thank you enough for the work that you do and for the hard data, because, you know, I have a clinical background, and, you know, you could talk to people about the importance of best care, but now we're not just saying this is the best care. Here are the numbers to back it up.
Right.
Here is the data. And so that is a winning combination. And with that, just please know in Arkansas, we do have office hours to answer questions about the collaborative care model. The third Friday of every month. And so please bring your questions if you're interested in collaborative care. We also do a stakeholder meeting the second Friday of the month. And we want to get you answers. We want to support you, and we want to move this further in Arkansas. So for our audience, please know those things are happening and we are here to help. Thank you all. Have a wonderful day and enjoy the beautiful fall weather.